So greetings and welcome to today's educational program, Assess and Improve Your Healthcare QMS with These Tools by Grace Duffy. This is your moderator, Doug Wood, with ASQ's Quality Management Division. Now, today we have the distinct pleasure of hearing from Grace Duffy. Please join me in welcoming her. Grace has over 45 years' experience in successful business and process management in corporate, government, education, and healthcare. Grace uses her experience as president, CEO, and senior manager to help organizations improve. She has authored 15 texts, additional book chapters, and many articles on quality, leadership, and organizational performance. She is a frequent speaker and trainer. Now, Grace holds an MBA from Georgia State University. She's an ASQ certified CMQOE and CQIA and Six Sigma Green Belt and certified quality auditor. Grace is a Lean Six Sigma Master Black Belt, an ASQ Fellow, and Distinguished Service Medalist. Grace is the recipient of both the Quality Magazine Professional of the Year and the Asia Pacific Quality Organization Miflora M. Gashian International Woman in Quality Medal. So, without further ado, it is my pleasure to introduce Grace Duffy. Grace, the floor is yours.
Oh, you're so kind. Thank you, Doug. And I do appreciate you hosting these sessions. It's been wonderful, and I've very much enjoyed being a participant myself. So thank you. And welcome to the participants. As I was looking at the list of participants, I recognize a good many of you who are very, very valued colleagues, and I do appreciate you being here with us. And I look forward to the questions and answers that we have. Some of you who are listening in to Doug and I ranting before the session know that this is the session that I will be providing pre-recorded during World Conference next week, and I really wanted to share this specifically with the Quality Management Division and those of you in the Healthcare Division who have signed in, because you are the ones who have helped create the Monograph Series that this information comes from. So I'm going to share information from our Monograph 3 of a series of the Healthcare Quality Management System series. And let me share with you what we're going to talk about, or what I'm going to discuss in this next hour. We'll look at an innovative hospital-based healthcare quality management system, which includes 10 quality system elements. And this is an overlap from, or an integration of the clinical side of healthcare delivery, care delivery, and the administrative support, the organizational and operational support that has to be around the delivery of that safe and high quality, high performance care. We'll look at the benefits of a systematic healthcare management system for continuous improvement, and then we'll identify some basic quality tools that are good for measuring and analyzing and improving based on those 10 quality system elements. Now, those tools are not going to be real high level complex tools. They're things that we can do every day. And I wanted to share these and examples of what we've done. And that's what the basis of Monograph 3 of the Healthcare Quality Series is all about. And this Monograph Series is available for free download from both the Healthcare Division website and the Quality Management Division website. Why did our team, the Healthcare Quality and Improvement Committee, the HQIC, why did we develop the QMS? We knew that a structured organization is the best way to be both effective and efficient. So we had a committee that really morphed from an early public health committee through the Healthcare Division and the Quality Management Division in collaboration. And over the years, it broadened into a general healthcare environment, just simply because public health is so integrated into what we do in not only corrective care, but in palliative care as well. And we've had this task group for a good many years now, probably about 12. And so this Monograph 3, which is the hospital-based healthcare management system model, but the Monograph 3 is for tools that are applied to this healthcare model, is really the culmination of the development of the model itself, which I'll share with you. We're now working on Monograph 4, which are real success stories based on those 10 quality management system elements, and we hope to have that available by the end of this year. Now, the model itself provides a foundation for the leaders who improve patient outcomes. Certainly, safety is critical. Safety, satisfaction, customer and patient satisfaction, obviously those two are not necessarily the same. Patients, yes, are customers, but a whole bunch more customers than that. We're also looking at cost savings, and then with the latest ISO 2015 changes, we've integrated risk management into the mix here. And then regulatory compliance has been an issue for a good long time, and we really cannot ignore that. Now, the hospital-based healthcare QMS structure is really a bridge. And some years ago, one of the healthcare division chairs suggested that we should identify a specific healthcare quality management system. Now, many of you know that in the accreditation bodies for healthcare, there are two major accreditation systems. There's the Joint Commission, which is based off of the Baldrige side, and then there's DNV out of Europe, which uses the ISO structure. So we have been very fortunate to have some of the DNV leaders be members of the quality management, the HQIC committee. And so we have had an opportunity to get some real expert input from ISO technical committee members, from healthcare ISO specialists, to make sure that we are as consistent, but also as generic as possible, because this quality management system can be used for a veterinary organization. The model is quite flexible and quite scalable. And so we can use it effectively as an overarching structure, but we need to understand it and look at the interfaces of what it does. Why is this QMS useful to our healthcare community? We're looking for a foundation. We're looking for something that, yes, is generic, but also can be used to transition from one environment to another as our technologies change, as our communities change, as we come into the science of what we're doing in healthcare. So this process-based approach, it is, as I say, consistent with both the Joint Commission and DNVGL. Now, for those of you who are aware of Baldrige, the Joint Commission takes that strategic approach first and comes down into the organization, into an effective system that works together to provide that quality and safe patient care. The DNVGL takes the ISO approach that says, what are the tasks, what are the components that we have to do to provide quality and safe patient care, and comes from the task level up. Well, it doesn't matter. It depends on your style and it depends on your approach as a leader within the healthcare organization, which way you want to go into that continuum. Either way, you have to get to the implementation. And so you'll find that the healthcare quality management system allows you to look at your organization from either side, but it uses the structure of the QMS to be able to get there. We look at that fact and database decision making. We do include the management of information. We do include some financial information, very big on feedback and improvement and measurements. We're also looking, as I said before, about the risk-based allocation of resources. Risk is an issue now. Many of you who have been involved in healthcare for years have known about the failure mode and effects analysis approaches for errors or for near misses and those sorts of things. And we don't want to minimize the importance of those activities. In fact, we want to encourage their use, and we want to drive the excellence of patient outcomes. And we also want to be aware that we're attuned to the current standards. As I say, we're based on the international ISO concept, and we want to look at both the value of the clinical and allied health as well as the administrative roles. And those of you who heard Doug and I talking before the session began, we know, and there have been conflict because of the different objectives and the different perspectives of members within the healthcare environment. And the QMS recognizes that is an issue that needs to be addressed in the long term. Now, this is the illustration of the model as a whole, as it was announced in Monograph 1 back in 2016. This is the healthcare, the ASQ Joint Quality Management System, Healthcare Division Quality Management System model. You can see in the center, in the core, is exceptional quality and safety and patient outcome. We want to make sure that the patient is the center of what we do. Now, soon after that, in that middle circle, is the delivery of care. So we want to recognize that the producers of the real frontline producers in a healthcare system are the clinicians, and we know that. The hospital is there to provide patient care. As you heard, I had lunch with a very, very close friend of mine. Actually, I'm his pseudo-aunt, who is a doctor of osteopathy, and he is a pediatrician and a pediatric surgeon in a rural hospital in North Carolina. And we just had that conversation today over lunch. Now, we looked as a committee at the 4 components of care, and something that the committee keeps reminding me, because I'm on the administrative side. I'm the CEO, I'm the chief operating officer, I'm the worker bee over here, and I don't see the clinical side as much. But this, even though we show that there is a sequential cycle of patient identification and assessment, development of the treatment plan, delivery of care, and the transition of care, certainly the transition of care either to the patient's home or to a rehabilitation area or to another specialty or to a reassessment in a different protocol, whatever, we show this as a sequential, and we all know that's not true. We're taking 2 steps forward and 1 step back. We're doing what we need to do because the human genome and the human body does not respond the same way as a gauge R&R in some manufacturing plant. It just doesn't work that way. So we have to be somewhat fluid in how we work with our patients and how we identify the systems that we put in place to facilitate this safe and quality care for our patients. But as that cycle, which is more like a Mobius strip than it is a circle really, in providing care to our patients, there are a number of operational elements that are the outside circle here that we realize we need to be aware of. Many of these are going to look familiar to you for those of you who are involved in QMS and those of you who are involved in the Baldrige. Certainly, leadership, commitment, planning, and review. For any of you who are aware of the quality management body of knowledge or the HBOC, for those of you in healthcare, and in fact in Six Sigma as well, we have to start. It starts with the leadership. In Baldrige, the whole idea of item number 1 is, who are you as leaders? How do you want to lead? How are you going to approach your organization? Because unless you have that structure, you cannot provide reliable and sustainable product and service to your clients and your customers. So we have to start with that. So we have that at the very top of the model. Next is we need to be able to communicate with each other. We need that transparency. So feedback loops are really the next approach that we have. Then we need to make sure that we have the environment to provide appropriate care, that we've organized it in a way that is scalable, a way that is modifiable, that it can grow with the population and the demographics of those we serve. Certainly, we need to be able to manage finances and support resources. We have to make sure not only that we provide care to the patients today, but that 2 weeks, 4 weeks, 3 years from now, the doors of the hospital or the facility are still open so that we can provide continuous care to this population. Management of information, electronic medical records are huge. We've got to be able to share medical information. We have to be able to share patient information. There's so much involved now in quality 4.0 and technology 4.0. We need to be able, in fact, people are starting to talk about quality 5.0 and information and AI, and medical science is all about being able to use as much data effectively as possible. Getting a little bit back onto the human side again, communication, education, and training is critical. Healthcare is changing just as quickly as any other science or technology. out there. We've got to be able to communicate new ideas. We need to be able to work with each other. We need to be able to provide education to our patients, to their families. We need to be able to train our own employees and our staff, things that we have to do. Now, certainly, excuse me while I go after a little throat lozenge here. It is spring, by the way, in Florida. So we still need to be able to communicate. As I mentioned earlier, risk management is huge. We cannot do it all. Hold on just a second. It's important that we understand what we can do and what we cannot do with the resources that we have. We have to take risks. Now, doctors are aware of that. Nurses are aware of that. Pharmacists, pharmaceutical PhDs are aware of that. Laboratory scientists are aware of that. We're making decisions all the time. And we need to understand how to manage those risks. And we need to be able to communicate our decisions around those risks. Certainly, we need to manage change because it's everywhere. And when you're working with human beings, those changes can be very unexpected. Teamwork, very close to the communications, education, and training. We are all in this together. We need each other. Medicine is just too complex. The human body is too complex. The organization in providing health care is too complex for one person to be able to manage it. We need to be able to understand the strengths of each other. And then compliance with requirements. We've got to standardize. We've got to be able to provide care on the East Coast, have somebody go to the West Coast or somebody go to Europe or somewhere else and find that they can still get the same kind of treatment they need or close to it. So requirements and standards have been globalized more than just nationalized for some time, especially in healthcare. And then finally, you can see off to the lower left, the whole yellow platform or orange, light orange platform indicates that this whole model is under continual improvement. The feedback loops and the data and the communication and the risk management is all intertwining to make sure that we are learning and that we are using those lessons to improve our delivery of care to the patient, our communications with their families, our ability to provide a broader community environment that will support the health of the whole community. And I think we've seen papers recently coming out of the major journals and the federal agencies talking about the hospital now being the foundation, being the core of the health and the safety of the community. And the hospital is going to be looked at as the coordinator for a lot of these different agencies and programs. Now, I've taken a while. I just took you through these 10 quality system elements. This might be a little easier for you to look at those 10. I won't go back through them again. They're all described in Monograph 1, again in Monograph 2. We refer to them certainly in Monograph 3 because Monograph 3 has segments and annexes for each of these quality system elements based on tools. And I'll show you 4 or 5 of them as we go through today. Now, this Monograph series, as I mentioned, 1 through 3. Monograph 1 is the basic announcement of the model. That's the management system model, and that came out in 2016. Monograph 2 was interesting. We hadn't really expected to get Monograph 2. We thought we were going to be able to go right into approaches and tools, but as we announced the model, people wanted us to become slightly prescriptive, which frankly surprised us. We thought because of the Baldrige approach of do not be prescriptive, provide an approach, provide a model, and allow organizations to manage it themselves. Well, that's a matter of style. There are some organizations that prefer to organize it and strategize it and build it and design it themselves. There are others who would prefer to see an example first and be guided and then make the modifications as appropriate for themselves. So it really was a surprise to us that we were getting an awful lot of requests for an assessment tool. So we built one, and it's a pretty good one actually. as you download any of these monographs from either the Healthcare Division website or the Quality Management Division website, you'll see that there is a flow, a cascading of information from each of these monographs. So the assessing one in Monograph 2 came out in 2019, and then Monograph 3 came out right at the Medical Mondays seminar in November of 2020. We were really pleased that Monograph 3 was sort of the bonus gift for Medical Mondays session coming out of ASQ. We were really honored to have it be chosen as that. Then Monograph 4, as I say, is about 80% done. I have started coordinating all of the different quality system examples. Several of you who are on this call have written some of those examples, and I greatly appreciate your assistance. We're very close now. I think we'll start into the rhetorical editing, probably the end of June, first part of July, and we're hoping that we'll go into publication maybe back end of August or September. We're hoping, again, to be able to have it available by the Medical Mondays, and whether that's in October or November, it's still a TBD. So hopefully that'll be available before the end of this year. Now, this is not an eye test, but just to show you how we organized putting together the tools for the quality system elements. The idea of Monograph 3 is that for each of the 10 quality system elements that are on the top row here, there would be tools, and we ask our writers, our authors, contributors, to identify tools that they use in their own environment, in their own healthcare system, their own public health system, in their own local pharmaceutical or laboratory, what tools they use. And we have people from a jail in Chicago. We had people from hospitals in Houston. We had people, consultants in Knoxville, Tennessee. We had quality managers, senior quality folks from Wisconsin who have developed all this material. As I say, we had leaderships from DMV, and we also had leaders from the Baldrige, or the Joint Commission, providing some of these tools. And you'll see that this was just a matrix, and it's not complete. It's just this Excel chart kind of goes farther down. If I were able to scroll up a PDF, and I can't, but you'll see that some of the tools that we found that we had good examples for, the break-even analysis and payback analysis and brainstorming and an FMEA and a cause and effect. See, these are not fancy, sexy kinds of tools. They're things that we use all the time. And we ought to be able to pull these things out of our back pocket to be able to use them. Now, some of you may not know about the SBAR in the bottom, and I'll show that one to you. I pulled it because I was not familiar with it to begin with. It's a great communication tool in sharing information with leadership. So I'll move on, and then we'll get into these tools. Excuse me. I've underlined the tools that I was able to pull out of the Monograph 3 to share with you today. If I were to take you through all of these, we'd be here until 8 o'clock, and I know you have other things to do this evening. By the way, I'm on the East Coast, so for those of you who are watching this in California, no, I'm not going to go until 8 o'clock your time either. But these are all the tools that are described with examples, with real live examples that the authors have used. So I'll share the X matrix, I'll share the Trimetric Matrix, because we are data-driven in what we suggest. Excuse me just a minute. Oh, and I see that Doug has given you the links. Ooh, thank you, thank you, thank you, thank you. That was wonderful. Process flow, that came out of the Mayo Clinic. SBAR is the one that came out of the Chicago Penal System. Audit Plan Checklist is one actually that came out of Monograph 2, which was really great, and also out of the College of American Pathologists. So we've been really fortunate to have some very, very expert contributors. Now, what I'll show you, each of the sections for the quality system elements, the 10 elements, has two tools. We describe what the quality system element basically does in maybe 3/4 of a page. It's not like you have to reread Model 1 to get to Monograph 1 to get to Monograph 3. But what we do is we describe the tool, and then we have an example of what it looks like. So, and some of these things, in all of, you'll see we give attribution. We did not rewrite some of these things. We went into Quality Progress, or we went into some of the Quality Press textbooks. We used some of the downloaded tools from ASQ.org so that we aren't coming into really remote and strange books for you to get information. We wanted to provide information that you can get to relatively quickly and easily. We don't want to make this difficult. So we talk about what an X matrix is. Some of you have used the X matrix term, Hosch and Conry, in ASQ strategic planning for either your sections or divisions. And the next slide, by the way, is the bow tie chart for those of you who are aware of it. And it's a planning process. And many, many hospitals use the X matrix to make decisions. So we have a description of the tool. Matrix generally use 1 to 3 tactical actions per initiative, and there are metrics linked to it. So I'll change the screen and show you a bow tie matrix. Some of you are going to yawn because you use this thing so often that it's not a surprise. Others of you may have not seen one before. And really, you just go clockwise around. I don't know whether you can even see my pointer here, but you can go from the bottom of what are the objectives of your organization, and then this matrix over here, the X matrix, then ties the objectives to the major goals, actually the objectives to the major tasks and activities in the strategically of where you're going, top level short-term improvement initiatives. Then again, you attach what is the connection between which of these activities supports the objectives on the bottom. Then you go up into the left-hand quadrant and the upper left, and then you tie those short-term improvement initiatives into top site level improvements. Okay, how are we going to do that? What are we going to do to get to this objective, this initiative? And then finally, we're going to set our measures, and how do we measure each of our site level improvements, and what are the critical metrics to improve that? And then some of these matrices even take you into who are we going to assign to do that. So it's a really useful tool. I'm not going to teach you the tool right now, or again, we'd be here forever. But that's one of the tools that's described in Monograph 3. And then there is a procedure for how you perform this function. So the procedure shows up in each of the 10 system elements. So there are 20 tools in Monograph 3, 2 for each of the quality system elements. The Trimetric Matrix is one that we published with the Public Health Foundation many, many years ago. Ron Bialik, who's president of the Public Health Foundation, and Dr. Jack Moran and I put together a very, very early version of my modular Kaizen concept. We did sort of a test case with the Public Health Foundation and used this Trimetric Matrix where you measure, do I have capacity for the process I'm trying to run? Have I defined the process? Do I have measures to make sure the process? Do I have leading indicators for the process? And do I have lagging indicators for the outcome? And then the Trimetric Matrix, and this happens to be an example of measurement for dentist screening. What am I doing? I have an indicator. Do I have oral health professionals to do the screening? What does the screening mean? What is the baseline measurement to make sure that I screen my students for dental health? And then what is the target? So that's the matrix. And then there is a description on a basic procedure. And you'll see feedback loops and measurements and how you would use it. Then we come into the process flow, and there is an illustration here, and you'll see that this one comes from the Mayo Clinic in a process that one of our authors provided for us. And you'll see, again, a cycle, a process flow. This is not a flow chart. It is a process flow. So it is a continuing adapting and leadership development, a continuing flow, not necessarily a step by step, but it is a flow of what the process is to do. And then there is a flow, and this is an example for the environment of care quality system element. Describing process flow diagram indicates a sequence of work at a level of detail appropriate for the concept being defined. It's not a work breakdown structure, it is a higher level. So we describe one of those. Then we get into the audit and assessment approach. And this is a chart directly out of Monograph 2. And one of our authors said, well, why should we build a new one? We put one into Monograph 2 and it's working really well. And so it's a series of questions. And I just pulled one of the assessment pages out of Monograph 2 in looking at, for each of the 10 quality system elements, and here they are listed on the left column, answer the following 4 questions, and then see a summary of the self-assessment participants' consensus. You would then keep notes as to the consensus of the assessment results. And then the auditor would then ask, should improvement initiatives be launched to address the issues identified in this assessment? It might even sound a little bit like a SWOT, but it's an organized, structured SWOT. Do the compiled processes and components fulfill the complete intentions of this QMS element? What, if any, revisions need to be made? What redundancies need to be eliminated? And what gaps need to be addressed in the existing processes? This is not earth-shattering. This is something that we all have worked on, but it's a really good tool to organize. It is a communication tool that a facilitator can use in running a planning and an assessment meeting, an assessment event. And then the auditor comments. How will the leader monitor these improvement initiatives and determine if the action plan needs to be revised? So it really is a good communication and tracking project management tool. Then in the sample audit plan, and this one we identify as part of the risk management quality system element, we describe an audit plan, what it is, capability. Many of you are auditors now, so I'm not going to teach you how to audit. That would be embarrassing. Besides, you're probably better at it than I am. But here we do make a point. Audits can be a preventive tool to anticipate gaps. We are looking at the assessment not as an FMEA on finding something that has already happened, but in anticipating what could go wrong, which is really what we want to do in healthcare. We really don't want to be cleaning up messes in healthcare, well, or anywhere else, as a matter of fact. So let's see where we go. Okay, then we've got the SBAR, and SBAR is not one that I was aware of, but I'm really glad there are a lot of tools out there. For those of you who have seen Nancy Teague's Quality Toolbox, second edition, what is that thing? It's almost as big now as Duran's Quality Handbook. There are a lot of tools there, and we don't use all of them. We're comfortable with some that work really, really well for us. Every once in a while, somebody will come up with another nifty one that we've not run into before, and we want to exploit it, want to be able to use it. And this SBAR ended up being good for that for me. Again, as a facilitator, as a Lean Six Sigma Master Black Belt, I like something like this because as we work with the executives in the organization, we look at what is the situation? What are we talking about? In this case, in a rehabilitation, a drug dependency rehabilitation center, patients are experiencing extreme dental pain. Well, as you know, some meth users and some other drugs really wipe out your teeth. And so there are issues here. And the situation, what's the situation? What's the background? Many of the patients, drug rehabilitation, have longstanding use of heroin and other narcotics, and their teeth are bad, several caries and abscesses. What is the assessment? Medical and dental staff need to provide medications that will relieve the pain, while you're hopefully performing treatment for these patients if they are willing to do so. And then what is the recommendation? And this is good because the nurses or the dental support in the rehabilitation center using this tool are allowed to be somewhat prescriptive in how they present information back to leadership to get resources and to suggest a method of treatment for the patients, prioritized by dental pain, whatever. So it's a really good communication tool. It's a really good guide to gather the information you need for a 2 or a 3 minute or a 5 minute agenda item with the CEO or with the resource owner, the sponsor or champion of whatever this procedure is. And then it's explained. The SBAR tool here can be used also as a leadership tool. We almost put the SBAR in as one of the 2 leadership tools, and then we realized that it is so flexible that we wanted to use it in communication, education, and training, just because it gets used and can be used wonderfully just to guide conversations. So here we have a description, when it's used, and the basic procedure. And each of the quality system element tools is described in this format. What I've done, and I've babbled at you for about 35 minutes now, and we've got some time, and hopefully Doug is finding some questions and answers, and we can get some good conversation. What I've tried to do is talk about this innovative hospital-based healthcare quality system that looks to bridge the clinical with the operational and administrative side of delivery of safe and high-quality patient care, also including the interaction. And these 10 quality system elements are interfacing back and forth with each other across that model all the time. This is much more an interrelationship diagram as a model than it is a PDCA cycle. It really is a total interaction. Like I say, 2 steps forward, 1 step back. You observe, you figure out, oh, I've learned more, let me back up a minute and regroup and come back at this thing in a more effective way. I've described the benefits of the systematic healthcare management system because it provides those feedback loops. It gives us the metrics. It helps us with lagging and leading indicators to make sure that we understand how we can do it better next time. How can we better apply a standard? How can we better meet that requirement? Many of you who use Press Ganey or PRC or some of the other national survey items are always looking to raise your performance against that national threshold of performance. And this model will help the organization to do that. And then we reviewed some of the basic quality tools. As I say, I haven't taken you through all of them. I wanted to give us a little bit of time to talk among ourselves. And for those of you, Doug, I'm going to hope that we don't expect me to have all the answers. From looking at some of the participants, there are people on this call who can do some really, really good benefit to answering some of the questions if they come up. So I'm going to hand this, well, yeah, let's see, I want to hand this back to you because you have some follow-up and some information on what's coming up in our next series as well. I do answer emails, and that is my cell phone number, and I also will respond to the cell phone. And now, I turn it off about 8:30 at night on East Coast time, so please, if you have a eureka moment at midnight, you're probably not going to hear from me. But I leave a voicemail, and I will call you back the next day. So, Doug, thank you. Let me give it back to you.
Grace, you don't have to. You can hang on to it. You don't have to give me the ball. I have got a couple of questions here that are coming up, and what I'll be doing, folks, is I'm going to be taking these questions, and we're going to be walking through them a few at a time. So we might not, get to all of them. You have Grace's contact, and by the way, Grace's contact information, her email address, will be in the email that follows the class in about 48 hours. So you'll be able then to reach out to her if you have a question. So our first question here was from Orlando. He says, do you believe that exponential technology will replace the health professional skills, exams, and surgery, et cetera? Just sort of a general futurist kind of question, Grace.
I like that, and I'm glad you're thinking about it. That we have envisioned that we can do so, that Gene Roddenberry came up with the idea of the medical pad back in the 1970s, late 60s, means that we can do it, and potentially we probably will do it. Do I think it's going to happen in my lifetime? No. Have we already done it somewhat? Yes. There are, I think Donella Meadows in her book Systems Thinking talks about the future is here, but it's in selective environments. It's not here everywhere. It's there in little packets. And yes, we're getting there. I am very, very bright about the future. Now, again, I am not a clinician. I'm not a data analyst. Well, somewhat, but not as good as many of you on the call. But yes, Orlando, I think we'll eventually get there. What worries me is that we also need to keep that human element in it. And for those of you who read Isaac Asimov, you know that that human element still needs to be there. And he knew that back in the 1950s and the 1960s. So yeah, gospel according to Grace, I think so.
Grace, I've noticed in a lot of companies they're discussing now the need for having people oversee the automation because automation is not flexible. The virus has taught us that we need to be flexible. All right, so here's another question from Naheem. He says, is there any recommendation on how to gauge patient satisfaction data in addition to sending out surveys? So sort of a general patient satisfaction information collection. How is there anything you found in the monographs on that?
Well, yes, there is. In the measurement area, in the management of change, and in feedback loops, and in finance and support resources, each of those quality system elements. And by the way, for those of you who can respond to this better than I can, I would also encourage you to start a running blog in the chat message, because other people can read those chats. And I know that there's a lot better knowledge out there among the participants on some of these questions than I have. So let me encourage that. We are, after all, colleagues. Yes. Doug, because I just talked like mad, ask the question again. Embarrassing.
The question was gauging patient satisfaction data. How do we do that?
A couple of different ways. Certainly there's PRC, there's Press Ganey, there's Leapfrog. There are a number of different really excellent national surveys and patient data. But just the nurses giving feedback as they are doing their rounding and calls in the morning. Now, the physicians are probably too busy, and they are so focused on the patient's symptoms and data and blood tests that they probably aren't as attuned to the patient's psychological situation, although some of them most wonderfully are. A lot of it is trying to assess eyeball to eyeball. One of the things that I've noticed when my husband has been in the hospital, when I have visited friends in the hospital, fortunately I'm disgustingly healthy and I just haven't had personal knowledge of this yet, knock on wood. The patients, the nurses, the caregivers are so aware of the patient's need for connection, for human relationships, and so aware of the patient's immediate satisfaction. You see those whiteboards now that are in the hospital rooms where the nurses, every time they come in, say, I am your shift nurse, this is who I am, or I am the person, your phlebotomist, and they're giving you their names. They're looking at you. They're asking you questions. Sometimes on that whiteboard, they'll even say, what is your state? And they'll draw the little smiley face or the frowny face. They're really attuned moment to moment to your satisfaction and your family's satisfaction when they're in the room with you. And I'm noticing a desire on the part of healthcare professionals to be closer and more observant over the last 5 years than before. Now, I don't know whether any of you else want to put a chat in for your own experience, but I have been pleased with more of the desire. Yeah, Rowena, here's Sana right here. We do leader rounding and also post-discharge callbacks. Good point. And Debbie Meeks, yes, leadership rounding with patients. Thank you. I knew you guys were out there, and I know you know it better than I do. But I've seen it just as a family member. There's a higher level of care immediately for the patient's satisfaction.
Okay. I have a question, Grace. You know, I'm looking at the tools, and I'm looking at the 10 elements, and I guess I'm wondering if it's like a big bite to take on, you know, got 10 elements, right? Try to hold 10 ideas in your head at the same time, or to be how Is there any thoughts on how you can make this kind of a context-specific pop-up or something that can help people get to the right element when they need it?
I love you. You are good. Folks, I did not pay him to ask that question. I did not feed him that seed question. Monograph 2 is a series of assessment questions, those pages. I showed you one chart of it that allows you to prioritize. It almost helps you build a Pareto diagram of where do we have the highest risk? Where is our highest exposure? So that you can focus in on the areas that you really need to bring up to a minimum level of performance. Now, to a certain extent, you've got that in the PRC or the Press-Ganey or the leapfrog or whatever it is. But for you, literally in your own facility, you're asking that question of the subject matter experts for each of those quality system elements. It's not like it's going to take you all day to do that. You should be able to go through one of those charts at a high level, maybe 20 minutes, 40 minutes, and you'll know if you get the right people in the room that we're strong here, we're weak here, or this has been really, really good in the past, but somebody's retiring and we have to rebuild the skill. And it'll help you set up your Pareto chart of where you want to start. Doug, I don't know whether I answered the question or not.
I think so. I think so. I'm recalling a video that we put out some time ago working with the College of American Pathologists. It was a doctor from the Children's Hospital in Seattle.
Yeah.
And they were talking about huddles, okay? Yeah. And I was thinking that, you got these 10 elements. Maybe you don't run through all 10 in every huddle, but maybe every third huddle you do 3 or 4 of them. Now that might be one way to kind of bring it into the thinking, the active thinking process.
That's a nice thought. Thank you.
I like that. Is there any, I don't know how well that video worked. We don't have that video posted anywhere because it was extremely different. We had 7 high resolution videos and things like that. So okay, Donna here. Donna says, I like tech and touchscreen kiosks to collect real-time data at point of service, and that's what she's saying here in the
I like that. And Donna is one of the auditors, the senior auditors at the College of American Pathologists. So she are one. I'm glad you brought it up.
I'm kind of excited that you mentioned them because a number of years back I did some work with them on a cost of quality class for them.
Cool.
So I've been to Chicago several times on that.
That's great. Yeah, I told you there's some real crackerjack people on this call. Okay, what else you got?
Okay, there's a comment to me.
Oh, no.
We're not going to do that. We're focusing on your talk tonight.
We're all friends here. We're okay.
Yeah, but the I'm excited, Grace, to see this collaborative effort between the healthcare division and the quality management division, and putting something together to benefit all of us. And it's not just for quality, not just ASQ either. What you're talking about here is healthcare, and it's not U.S. health. It's not American. It's world healthcare, which is where we're going.
You are 100% correct. And by the way, the editor of the healthcare division newsletter is a physician in Saudi Arabia. He gets up at 2 o'clock in the morning to attend the healthcare division monthly calls. It is truly a global group. It really, really is.
Dedication.
Yes.
Okay, so I've got another one I'm going to ask you verbally here.
Okay.
This is from Joe. Joe says, what are the reasons / factors for the slow progress in healthcare to becoming a high-performing HRO when compared to other sectors such as aviation and nuclear power?
Oh, geez, that's a real stump the stars question, Joe. Oops. Gee, is it time to quit yet?
No.
The organizations are HRO, and we did talk about high reliability organizations, and we did mention it somewhat even in Monograph 1, because we can't ignore that we want to be consistently reliable. Part of it's resources, some of it, and I'm reminded of my conversation at lunch today with the DO, the pediatric surgeon and physician hospitalist. Some organizations, depending on their leadership style, and especially if they're, well, no, never mind. I'm going to get in trouble if I say that. High reliability organizations take a lot of effort. It takes an incredible amount of emotional and psychic energy to keep all those balls rolling at once. Doug, just like you talked about, keeping all those 10 system elements going, it is a symbiotic relationship. It takes more than 3 people to do that. It takes intense communication and trust to be able to do that. Now, some corporations are able to be at a higher level than others simply because they have that level of drive, but they don't last forever. It's like being at maturity level 5 all the time. It's like always being the national U.S. Baldrige winner for your industry and staying there all the time. People get tired. Things change. The CEO changes. The chief medical officer changes. You're bouncing up and down from HRO, then you're bouncing down to a level 4 maturity for those of you who are aware of the process. And we talk about that, by the way, in Monograph 2. And it's not easy to keep that level of intensity. It's just really not.
I came across the text from Clayton Christensen.
Probably that word, that name, yeah.
Yeah, about 15 years ago. About 15 years ago, he did a book on what was it? The Disruptor's Prescription, something like that. He was talking about healthcare change and healthcare improvement. And it was probably one of the densest books I've ever seen. I mean, every page had an idea, right? And it's a big book. But I found it helpful to picture the healthcare system and try to get your arms around it as a whole. If I could say something here about the slow progress in healthcare, I think part of it has to do with the healthcare as an industry is oftentimes driven by regulation. Oh, yeah. In other words, if it's not regulated in, it doesn't get done because they're already doing something that is so inordinately complex. You know, the health of humans or the health of any creature. It is so, our bodies are so complex. And then you say, well, we're going to change the way we go about doing it. It has to be, it's regulated. The regulators in healthcare, though, according to Christensen, it's the insurance companies.
Oh, yeah. Oh, you're so right about that. Oh, yes, yes,
yes. And where are insurance companies looking at, HRO? Yeah. They're really not. It's not on their radar to work on that, I think. So I would argue that that's a factor, Joe, to hurt that, okay?
Thanks, Doug. By the way, I'm seeing emails come in. I've got my laptop over here on the other side, and I'm seeing emails coming in from people asking for the slides and also asking for the monographs. So I'm more than happy. My email address is right there. So if you want me to now, with 96 people on the call, it might be forever till I can send that many emails. But yeah, we'll do the best we can. So Doug, let me hand it to you back to do the final couple of slides and then get our folks out by 7 o'clock.
Grace, you can just move it. Just change a slide. You'll do that.
Oh, yes, Grace, you have the, yes, I can do this. Okay. Okay, got it. Thank you.
Yeah, before we just close out here, I want to mention Susan Pfeiffer's point. She says HRO challenges are also a high rate of change, highly regulated, and in the U.S., it's tied to reimbursement. Healthcare's product is people, so that's a great point. All right, so we want to, kind of do some closing here. We've done our questions and so on and so forth. We're gonna stop the recording here. Thank you for watching the recording, but then we're gonna finish up with a few items.